The basis of trauma management is to identify and treat injuries in order of their potential risk to life. As a result, management is rarely an orderly progression through primary survey, secondary survey, investigations, and treatment. Often, secondary survey investigations may have to be delayed until after problems identified by the primary survey have been dealt with, and often by the time the patient is in the ICU. We're going to go through a case to illustrate some of these issues. You are asked to see a 25-year-old driver who was involved in a frontal impact motor vehicle accident with an impact speed of 60 kilometers per hour. He was wearing a seatbelt. The likely injuries can to some extent be predicted from the mechanism of injury. Patients involved in frontal impact vehicle injuries are more likely to suffer cervical spine fractures, anterior flail chest, myocardial contusion, pneumothorax, aortic tear, ruptured liver or spleen, and fracture or dislocation of the hip or knee. Your first priority is primary survey and immediate resuscitation. Start with A. His nose stridor and there is palpable gas movement. Then B. Chest expansion is reduced on the left and he's using accessory muscles. His respiratory rate is 35 per minute and his pulse oximetry is unrecordable. He has decreased breath sounds on the left, possible hyperresonance on the left, and tracheal deviation to the right. Moving to C, his blood pressure is 80/50, heart rate 120 per minute, his neck veins are distended, and he has cold peripheries with slow capillary refill. In trauma patients, shock is usually due to hypovolemia, but you should also consider tension pneumothorax, cardiac tamponade, myocardial contusion, and myocardial infarction. Clinical features of a tension pneumothorax are respiratory distress, tachycardia, shock, tracheal deviation, although this is a late sign, unilateral absence of breath sounds, hyperresonance, and distended neck veins. But beware that neck veins are often not distended if there's concomitant hypovolemia. The differential diagnosis is cardiac tamponade. Our case has features of a tension pneumothorax. So you perform a needle thoracostomy in the second intercostal space in the midclavicular line, and the diagnosis is confirmed by a gush of air. Remember, a chest drain should always be inserted following a needle thoracostomy. Typically in trauma, a 28 to 36 French gauge drain is inserted in the fifth intercostal space just anterior to the mid-axillary line. Of course, it is also important in trauma patients to obtain large bore IV access. The patient's circulation improves and now his blood pressure is 90/60 with a saturation of 95%. He's tachypneic but has symmetrical chest movement. What target blood pressure do we want? In general, aim for a systolic blood pressure of 80 to 100 millimeters of mercury in patients who have not suffered head or spinal injuries and in whom early hemostatic surgery is feasible. Resuscitation to a higher blood pressure may disrupt blood clots, exacerbate dilutional coagulopathy, and exacerbate hypothermia. A chest X-ray should be performed early, although the exact timing is not important. As the patient has now stabilized, this is a good opportunity to take the film as well as put on a pelvic binder if there are any signs or symptoms of a pelvic fracture. Remember that a chest X-ray is the one X-ray that is justified in an unstable patient. In our patient, the chest X-ray shows left-sided rib fractures and contusion of the left lung, and a chest drain that has been inserted too far. D is next. The Glasgow Coma score is E2, V2, M4, and his pupils are 3 millimeters, equal and reactive. You decide to intubate and ventilate the patient for airway protection. Frontal impact motor vehicle accidents are associated with cervical spine injury. Cervical spine injury cannot be excluded on clinical grounds, even with normal cervical spine x-rays, due to the presence of distracting injuries or decreased consciousness. Therefore, we have to assume that our patient has a cervical spine injury. The optimal method of intubation under these circumstances is controversial and dependent on the skills of the operator. You decide to attempt direct laryngoscopy and therefore need manual inline stabilization. What instructions would you give your assistant? Stand in front of the patient and to one side. Hold the mandible and occiput with both hands, and maintain neck alignment without traction or counter traction. If you're going to use direct laryngoscopy, a rapid sequence induction is recommended. Pre-oxygenate the patient with a tight-fitting face mask and 100% oxygen for 3 to 5 minutes. Use cricoid pressure. This may cause subluxation of an unstable cervical spine, but there is no evidence that this results in a worse outcome. And use a bougie routinely. You fail to intubate the patient, but luckily the anaesthetist arrives and takes over. She decides to attempt direct laryngoscopy and intubation again after bag mask ventilation. In order to open the airway for bag mask ventilation, she performs a modified jaw thrust. To do this, she places her fingers on the ramus of the jaw and lifts the jaw anteriorly, using her thumbs to open the mouth. After bag mask ventilation, to ensure adequate oxygenation, she then intubates the patient successfully. The take-home message from this is that trauma patients are more difficult to intubate, and you should not attempt intubation unless you are skilled in intubation or it is a dire emergency. Airway protection, as opposed to airway patency, is not a dire emergency unless the patient is regurgitating or bleeding from the upper airway. The other take-home message is whenever you attempt intubation, it is vital to have a backup plan for failed intubation. As I mentioned before, the patient has a potential cervical spine injury, so it is important to immobilize the neck. You note that his blood pressure is now 75/40, with a heart rate of 120 per minute, despite transfusion of 2 liters of crystalloid blood. 300 mils of blood has been drained from his chest drain. His clinical features suggest he's lost around 30 to 40% of his circulating volume, is bleeding significantly, and should be given IV tranexamic acid early. There's no obvious external bleeding, so you need to consider sites of occult bleeding, such as the peritoneal cavity, the pleural cavity, major fractures, and retroperitoneum. He has a negative FAST scan, but his blood pressure is 80/40, only with continued fluid resuscitation, and he has progressive abdominal distension. Is the bleeding source in the peritoneal cavity? Focused abdominal sonography for trauma, or FAST, is operator dependent and even in trained hands is insufficiently sensitive to exclude significant intra-abdominal injury. Unexplained blood loss, abdominal distension, and frontal impact motor vehicle accident make intra-abdominal bleeding very likely. Options for further investigation of abdominal injury include CT abdomen and laparoscopy. But CT is contraindicated in this case because of hemodynamic instability. So a decision is made to progress to emergency laparoscopy. Post-operatively, the patient comes to the ICU and is admitted by one of your colleagues. What history would you want from the anaesthetist? It would be important to know the mechanism of trauma, identified injuries, injuries that have been excluded, operative findings, supportive and definitive treatment, blood loss and blood or fluid transfused, laboratory results, and past medical history and drug allergies. She should then check the ABCs, checking the position of the ET tube and that it's properly secured. She should then go on to check both sides of the chest are moving and being adequately ventilated, the saturation and the arterial blood gases. She should make sure there is an adequate IV access and appropriate monitoring. Assess the blood pressure, heart rate and perfusion, level of consciousness, and limb movements. The cervical spine should be kept immobilized until cervical spine injury has been excluded. In addition, it is important to prevent hypothermia. It is also important to identify or exclude other injuries by conducting a secondary survey. Remember that you did not get beyond the primary survey before the patient had to go for a laparoscopy. This involves a thorough head-to-toe examination, which should include examination of the scalp, eyes, maxillofacial region, spine, neck, and perineum, as well as more obvious areas such as neurological system, cardiovascular system, chest, abdomen, pelvis, and limbs. The patient should be log rolled to examine the back and to perform a rectal examination. Investigations should include routine blood tests, radiology, and an ECG, given the risk of myocardial contusion in frontal impact trauma. Radiology will depend to some extent on local practices and what injuries are suspected, but commonly involves a CT from head to pelvis. ICU management includes continued resuscitation, correction of coagulopathy, acidosis and hypothermia, all of which contribute to further bleeding, and treatment of complications. Although hypovolemic shock must always be considered in trauma patients, distributive shock may occur in the later phases due to a systemic inflammatory response. Spend the next minute thinking about and writing down 3 take-home messages from this lecture. In summary, start with a primary survey using a methodical ABCDE approach and resuscitating as you assess. If an immediately life-threatening injury is identified, it may be necessary to interrupt your assessment for emergency treatment. A secondary, more detailed survey should be carried out after the primary survey or after emergency treatment of any immediately life-threatening injury. This should be supplemented by appropriate imaging.